First described by Dr. James Parkinson over 200 years ago, Parkinson's disease remains one of the most common neurodegenerative disorders. Let's examine its features and management. Parkinson's disease is a chronic and progressive neurodegenerative disorder. It is primarily caused by the loss of dopamine-producing neurons in a specific area of the brain called the substantia nigra. This neuronal loss leads to a wide range of motor and non-motor symptoms that gradually impact daily functioning. The pathophysiology of Parkinson's disease involves degeneration of dopamine-producing neurons in the substantia nigra, resulting in reduced dopamine levels within the basal ganglia. Additionally, abnormal protein accumulations known as Lewy bodies, composed of alpha-synuclein, are a key pathological hallmark of the disease. The majority of Parkinson's disease cases are idiopathic, meaning the exact cause is unknown. However, certain genetic mutations such as PARK1 and LRRK2 have been implicated. Secondary causes can also trigger Parkinsonism, including exposure to specific drugs like antipsychotics, toxins like MPTP, and repeated head trauma. Clinically, Parkinson's disease is classically remembered by the acronym TRAP, tremor at rest, rigidity with a cogwheel or lead pipe quality, akinesia or bradykinesia, indicating slowness of movement, and postural instability leading to frequent falls. Additional features include a mask-like facial expression, shuffling gait, micrographia, hypophonia, and various non-motor symptoms like depression, cognitive decline, sleep disturbances, and constipation. The diagnosis of Parkinson's disease is primarily clinical, based on the recognition of typical motor features. MRI is usually normal, but may be performed to rule out other neurological conditions. A positive clinical response to levodopa therapy further strengthens the diagnosis. Management of Parkinson's disease focuses on symptom control. Levodopa combined with carbidopa remains the first-line therapy. Dopamine agonists like pramipexole and ropinirole are useful, particularly in younger patients. MAO-B inhibitors, such as selegiline, and COMT inhibitors like entacapone help prolong dopamine action. Amantadine can be used to manage dyskinesias, while deep brain stimulation is reserved for patients with advanced medication-resistant symptoms. Complications of Parkinson's disease often arise from both the disease itself and its treatment. Patients may develop levodopa-induced dyskinesias and motor fluctuations, commonly known as the on-off phenomenon. Non-motor complications include dementia, increased risk of falls and fractures, and autonomic dysfunction such as orthostatic hypotension and constipation. Early recognition and management of these complications are key to improving quality of life. This is a brief summary of Parkinson's disease. It is a chronic, progressive neurodegenerative disorder caused by the loss of dopaminergic neurons in the substantia nigra. Core motor features are summarized by the acronym TRAP, tremor, rigidity, akinesia, and postural instability. Diagnosis is primarily clinical and supported by a positive response to levodopa. Management focuses on symptomatic treatment with medications like levodopa, carbidopa, dopamine agonists, and MAO-B inhibitors, while deep brain stimulation is reserved for refractory cases. Complications include dyskinesias, cognitive decline, increased fall risk, and autonomic disturbances. A multidisciplinary approach is essential for optimal care.